This presentation is going to cover the 12-lead interpretation of ischemia and infarction patterns. Before we get to the ischemia and infarction patterns, I would like to briefly review some anatomy of the heart and blood vessels. This will become important when we're discussing clot formation and ischemia and infarction. First of all, if this is review, please fast forward this through the video. Otherwise, this is actually a pretty good review. The coronary arteries branch off of the aorta directly above the aortic valvular leaflets. Now this is important because the leaflets will close during ventricular relaxation or diastole, and as the blood tries to back into the ventricle, the left ventricle, it will smack up against the closed aortic valves and then squirt into the right and left coronary arteries. The coronary arteries fill during this diastolic process. There are two major arteries that come off of the aorta, the right coronary artery and the left coronary artery. Of course, up here, as you can see, they are abbreviated as RCA and LCA. Generally speaking, because this can change a little bit based on the text you read or the human anatomy itself, the right coronary artery branches off over here on off of the aorta, and then it travels down the right side, and then you also have this part here called the marginal branch that breaks off as well, and it travels around the posterior wall a little bit also. Generally speaking, the right coronary artery supplies most of the right ventricle, or all of the right ventricle actually, part of the inferior and posterior wall of the left ventricle, the SA node in 55% of the population. Not 55% of the SA node, but 55% of the people have their SA node perfused by the right coronary artery. The AV node is supplied in 90% of the people. So 90% of the population walking around out there usually has their blood supply that travels to the AV node coming from the right coronary artery. And of course, the right coronary artery also perfuses part of the posterior fascicle of the left ventricle. The left coronary artery, which comes off over here, goes just a little ways here, just travels just a little bit of direction here, and then it stops because it bifurcates into the left anterior descending and the left circumflex. Now when we talk about the left anterior descending, a lot of times this is abbreviated LAD. You might have seen that before. It perfuses 40% of the left ventricular muscle mass. It also perfuses the His bundle and both of the bundle branches, and this is primarily because the left anterior descending artery perfuses the anterior 2/3 of the interventricular septum. If you have the LAD occluded by a clot, usually this will cause some pretty serious arrhythmias. It can very quickly lead to a VTAC or VFib, complete bundle branch block, or a complete heart block, and it could also lead to a fascicular block. The left circumflex artery comes off of the left coronary artery right here and travels back around to the posterior side of the heart. It will supply blood to the lateral and posterior left ventricular walls. It will supply blood to the SA node in 45% of the population, and it supplies blood to the AV node in 10% of the population. Remember, this is the people, not the percentage of the node itself. On a side note, statistically speaking, this is the artery that is the least likely to become occluded of any of the surface arteries. One more structure I would like to review is the arterial structure. It has three basic layers. It has a tunica intima and a tunica media and a tunica externa. But I want to talk about these real quick. The tunica intima is the innermost layer right here, the innermost layer of the artery. Now, it's also the innermost layer of the vein, but we're going to be talking about arterial stuff. This tunica intima is 1 or 2 cells thick. It is a very thin layer. It is only there to provide some substances that we're going to talk about here in a minute. It's also there to provide a nice smooth inner lining for blood to travel very easily and very smoothly through the arteries. And if you're curious, it contains simple squamous epithelial cells, if you were curious. The second layer that I'm going to discuss is the tunica media. The tunica media is basically smooth muscle. It's this whole area right here. The tunica media, or middle, basically is this area right here. This is the area that has the best ability to dilate or constrict to help control blood pressure or to move blood from one area to another, to shift major portions of blood from one area of the body to another area. In the heart, of course, you're probably just going to dilate or constrict it. You don't want a coronary artery completely closing off, so that's what it won't do in the heart. The last layer I want to talk about here is what's called the tunica adventitia. It's also sometimes called the tunica externa. This is how I learned it because it's the external and it was easier for me to learn. But the tunica adventitia, or the tunica externa, is this outer layer all the way out here. This is the outer protective layer. Let's briefly talk about the development of atherosclerosis. I'm going to try to go through this and explain it in a way that makes a little bit of sense. This is a very complicated process that occurs, but if you understand the process, it really makes a difference on how well and how quickly you can treat your patients. So the first thing I'm going to talk about here is how we start developing the arteriosclerosis. So I'm going to concentrate on this picture here. I'm going to start over here with number 1, the LDLs. Now let's briefly talk about the LDLs. LDL is basically a low density lipoprotein. A low-density lipoprotein has 2 other cousins, a VLDL, which is a very low-density lipoprotein, and an HDL, which is a high-density lipoprotein. LDLs are necessary in your body. A lot of people think that if there were 0 LDLs, there would be 0 problems, and that's not entirely accurate. The body needs low-density lipoproteins. Unfortunately, with some of the lifestyle and diets that we have today, LDLs are in very high quantities inside the bloodstream. This will actually cause a problem. The reason for this is that because under normal circumstances, endothelial cells in the bloodstream release substances to prevent adhesion of stuff like macromolecules, platelets, and monocytes, and that includes LDLs. So anytime you have an intact and fully functional endothelial lining like we have over here, these substances prevent adhesion of anything. It keeps the blood flowing smoothly through the veins. Unfortunately, any kind of damage that occurs to the endothelial lining prevents these substances from being released. Now, you don't always have to have a complete break in the endothelial lining, because LDLs, without these substances here to keep these LDLs out, they can just migrate their way right through the endothelial lining, even though it's intact, into the tunica intima. Now, this area down here is considered the tunica intima, the middle layer. Once these LDLs that have traveled through this damaged epithelium get into the tunica intima, there's a complicated process of mechanisms that occur that change these LDLs into an oxidized LDL. So what happens is this LDL becomes oxidized and it becomes a pro-inflammatory LDL. These pro-inflammatory lipids, then they cause the adhesion of a white blood cell called a monocyte. Once this monocyte adheres to this endothelial lining right here, because remember, those substances are no longer being released. Once this monocyte adheres to this endothelial lining, it will then actually differentiate, or it will change from a monocyte into something called a macrophage. Now, this macrophage has the ability to completely change its morphology or its shape so that it can squeeze in between these endothelial cells. Once it squeezes in between these endothelial cells, it will then attach to and then completely engulf all of these little oxidized LDLs. And that's what's occurring over here. Once this little oxidized LDL is engulfed, the macrophage will then try to break down this little LDL right here. Unfortunately, as it breaks down this LDL, it breaks it down from this complete substance right here to basically droplets, lipid droplets. These lipid droplets inside of the macrophage right here gives it a foam-like appearance. So it looks like that there's foam inside of the macrophage. That's where they came up with the term macrophage foam cell or foam cell. Now let's talk about what happens when you end up with a foam cell. Here's your foam cell right here. I crossed that out earlier. Let's see what happens once you get this foam cell. Once you have these little lipid droplets developing inside of this macrophage, it's called a foam cell because it looks like it's foam on the inside of the cell. This foam cell now releases these little substances. These little white dots right here are something called cytokines. Cytokines is just a chemical that causes something to happen. It's a substance released from a cell that causes something to happen. The cytokines that are released from this particular cell causes division of smooth muscle cells, which are all of these little pink things down here. These are all smooth muscle cells right here. It causes the division of these smooth muscle cells, and it attracts another cell called a fibroblast. Fibroblasts are responsible, in this case, for building or repairing collagen fibers. This is what's important right here, is the collagen fibers, and I'll explain why in a little bit. So, the cytokines that are released from the foam cell, here's your foam cell, the cytokines that are released causes the smooth muscle cells to start dividing, which also the cytokines call fibroblasts to come to this area right here and start repairing and building collagen fiber over the top of all of this damaged area right here. So how do we damage the epithelium? First of all, damaged epithelium can come from a whole bunch of different causes. We have your hypertension, smoking, hyperlipidemia, which is just high levels of cholesterol or high levels of lipids. Usually it's LDL that's the concern, because that's the one that's most commonly in higher abundance in the body. Hyperhomocysteinemia. Homocysteines are a specific byproduct usually of protein or meat metabolism, trying to break down the proteins into amino acids. You end up with a lot of homocysteines in the body, and that can actually damage the endothelial lining, because they're like little crystals that run around and they bump up into the endothelial lining here, and as they bump into it, they scratch it, basically. Hemodynamic factors, toxins, viruses, and even immunologic reactions. So let's look over here at the picture on this side over here real quick. Basically what happens is there's damage here. So in this case there's a break in the endothelium. But like I said before, your lipids do not need to have a break in the endothelium to get into the tunica intima. They can get right through intact endothelial layers as long as the anti-adhesion stuff is not being released by damaged endothelial cells. So basically what happens is you have this damaged endothelium and you have lipids that start making their way into the endothelial lining, underneath the endothelial lining into the tunica intima. Once the lipids are in here, they are oxidized and they now become oxidized LDLs. These oxidized LDLs start releasing chemicals that attract monocytes. As these monocytes make their way over here to the endothelial lining, what happens is they change their shape, they change their morphology basically, and they become macrophages. The macrophage gets into the endothelial lining and starts engulfing all of these oxidized lipids. One of the problems that occurs with this is that if you have high levels of lipids or LDL in your body, the macrophages or monocytes, which turn into a macrophage, because here's a monocyte, this right here, we'll just say that this is a macrophage. If too many lipids get into this little area right here, if too many lipids get in here, the macrophages can't keep up. It basically, you have way too many problems and not enough white blood cells to try to take care of those problems. If this starts to occur, you start developing these fatty streaks here. You start developing these little streaks, or these long, well, streak basically, of LDLs that are in the underneath the endothelial lining. With this lipid accumulation and this whole process of, remember these macrophages, what are they releasing? They're releasing stuff to build up fibroblasts, to build up the tunica media, and these little things right here are called fibroblasts. These fibroblasts are actually coming here to start building up this collagen cap right here. They're starting to repair this thing, they're starting to build it, and basically what's going to happen is you're eventually going to have this big fibrous cap that's going to be coming over the top of this entire area of injury right here. Now remember, this is building into the lumen of the artery. What's also occurring is this right here, this tunica media, is getting thicker, so it's actually pushing this whole problem further into the inner lumen of the artery. So that's why when you have an artery that has a wall that's something like this, as time goes on, the artery will actually appear to get larger while the inner diameter of the artery gets thinner, because you have the pushing and the building of the tunica intima, the tunica media. You have the building up of the tunica media and the smooth muscle, and the tunica intima is going to start building up this little fibrous plaque. So now look at this little area right here. Much thinner lumen, much smaller lumen. As time goes on, the lipids will keep accumulating in here to a point where you have this lipid pool, or this ooey gooey center of lipids that are in here with macrophages or foam cells or whatever you want to call them. And look what's happening up here. There's little fissures up here, because you're pushing everything in this direction. Your collagen cap, your fibrous cap, can only hold back for so long. It can only withstand so much pressure. Now, eventually what could happen is if you lower the LDLs in the body, this will potentially repair itself to a point. But a lot of people, they just keep doing everything that they can to try to keep increasing their LDL levels, and eventually what will happen is you will have a rupture of the cap. Now remember, these are collagen fibers in here. The one major substance that initiates the whole clotting cascade are exposed collagen fibers. So as soon as these collagen fibers are exposed, you're going to start developing a clot. Now, this is not entirely accurate right here because really this would be thickened up a little bit because of this whole process, but it's not. But you still have your cap that ruptured, and then now you're actually building a clot. Big problem right here because it won't take long for this inner lumen right here, this right here, to be completely occluded. This is what will happen if the wall or the fibrous plaque or the cap actually ruptures. What will happen is the exposed collagen fibers will then be exposed to the blood out here, which will then start the clotting cascade. And what happens is, as the clot begins to develop, it is very unstable, which means you're going to have little bitty clots that are going to be shoved downstream. So you're going to have little clots breaking off. This thrombus is going to be sending little emboli downstream. Well, this is kind of a bad thing because floating blood clots in the body are always a bad thing. Some reasons for the atherosclerotic rupture, for that fibrous cap to rupture. Well, if the plaque is located at a blood vessel bifurcation, or if it grows, and I'm just going to put that in quotes, it grows into a bifurcation, and it can rupture very easily. If you keep having increased levels of lipidemia, and like I said before, usually it's LDLs that are the bad ones. That's the ones that we normally have the biggest problem with, are LDLs. If there's a sudden surge in blood pressure or heart rate and blood flow, so people who maybe work out all of a sudden and they say you need to talk to your doctor first before you go work out if you haven't worked out for however many years. They don't go talk to their doctor, and they hit the gym and they start working out. It could send them into a heart attack. So extreme physical activity right here, extreme physical activity. Here's one of my favorite, not my favorite, but here's one of them that I always like to talk about is emotional stress, long-term or short-term emotional stress. I always like to think of the movie Casino, if you've ever seen the movie Casino. Towards the end, whenever all of the FBI agents are making their play and they're going in and they're arresting all of the mobsters, and there was one guy who kept a record of everything that he did whenever he was flying out to Vegas back and forth, and he kept saying that those were his mother's books, and he killed over from a heart attack right there on the spot. He probably had a huge increase in blood pressure, huge increase in heart rate, and a very fast increase in blood flow. A couple other things you could have is a coronary vasospasm at the site of the plaque, and you could also just have shear stress, which is friction from blood flow, and it just keeps going by there and causes it eventually to rupture. What are the risk factors of developing this atherosclerosis? Well, there's modifiable, non-modifiable, and there are contributing factors. Non-modifiable risk factors, that means you're probably going to end up with it whether you like it or not, is hereditary, or heredity, basically, gender. Men are more than likely to have the problem than women, and they've found some kind of a link to estrogen. The higher levels of estrogen in women prevent this process from occurring. And they found also that whenever women go through menopause and all of a sudden their estrogen levels plummet, then all of a sudden there's a huge issue with them developing or having a higher incidence of developing atherosclerosis. Race and age. The older you get, the better chance you have of developing this stuff. What they're finding nowadays, which is actually kind of scary, is that adults aren't the only ones that have these fatty streaks that are built up in the arteries. They're finding them more and more in kids now. And I'm not saying kids like teenagers, but kids as in pre-teens. Before they even become a teenager, they're developing these fatty streaks. Modifiable risk factors include alcohol intake, hypertension, or HTN is an abbreviation for hypertension, high lipids in the blood or high cholesterol. Smoking is a huge factor. drug use. Whenever we talk about drugs, we're actually talking about the recreational drugs and just good old-fashioned stress. And that's another problem that they're finding nowadays, is that more and more children are more stressed than ever before. It used to be kids never had stress. There was no reason for children to have stress. But they theorize now that with a lot of adult stress and a lot of the stress put onto them by media, that they're starting to develop the signs and symptoms of stress as well. So stress causes atherosclerosis. When we talk about contributing factors, what we mean by contributing is it doesn't directly cause atherosclerosis or arteriosclerosis, either one of them, but these increase the chances of you developing atherosclerosis. One of the contributing factors is inactivity or inactive lifestyle. If you have an inactive lifestyle, if you have the body by IBM, as you sit there and never met a calorie you didn't like and kind of a larger person, then you're definitely going to have more of a risk factor, a higher risk for developing atherosclerosis. Diabetes mellitus, or the blood sugar problem. If you have blood sugar problems, it's probably due to a diet, which is causing an inactive lifestyle. And then there's obesity. Clot formation. We've discussed recently the problems that occur whenever you have fatty streaks and how the macrophages or monocytes make their way into the tunica intima and become foam cells. The macrophages absorb or phagocytize or engulf, however you want to call it. They engulf those LDLs, those oxidized LDLs, and break them down into little bitty lipid droplets, which makes it look like a foam cell underneath a microscope, which of course also causes the phagocyte, which then causes the macrophage to release cytokines to call all these other cells in to start doing work and everything. And that's the process that leads up to the clot formation. Once that fibrous cap ruptures, then you have collagen exposed to the bloodstream. Once collagen is exposed to the bloodstream, a clotting cascade begins. A whole clot formation has to begin. Clotting is actually a very good thing. We need clotting. If you cut yourself shaving and you didn't have a clotting process, you're going to bleed for weeks, and you're never going to stop bleeding. Unfortunately, clotting that occurs inside of a blood vessel, it can be very deadly. Let's talk about the step-by-step process. I'm going to skip over a whole bunch of steps. So if you're expecting me to go into all of the intrinsic and extrinsic factors, I'm not going to go that deep. I'm going to try to keep this a little bit simple. The first step that occurs is something called platelet adhesion. This is the first step of the clotting process, is platelet adhesion. Now what happens is collagen fibers, in this case, here's your collagen fiber right down here. Collagen fibers are exposed to the bloodstream. When these collagen fibers are exposed to the bloodstream, platelets will attach to these collagen fibers. Once a platelet attaches to the collagen fiber, they release a couple chemicals. One of the chemicals is thromboxane A2 and another one is ADP. So when blood comes in contact with these endothelial cells, not the endothelial cells, that's actually not true, is it? It comes in contact with the collagen fibers. Platelets stick to those collagen fibers. When they stick to those collagen fibers, what happens next is granules inside of the platelets will then release the thromboxane A2, and it was supposed to be an underline, and the ADP. Thromboxane A2 will combine with serotonin, which is freely floating within the bloodstream, to help cause vasoconstriction. If this is because you cut yourself shaving, that's a good thing. Keeps blood from leaking out everywhere. Since this is not a cut yourself shaving situation, it's going to start causing vasoconstriction in an artery that is already decreased in size due to the thickening of the tunica intima and the protrusion of the fatty streak into the arterial lumen. Another process that occurs here is that the thromboxane A2 and the ADP help attract platelets to the same area. Now, the reason this happens is, let's just say that I have a bloodstream down, or a blood vessel wall down here, and I have a collagen fiber that's sticking up into the bloodstream. What will happen is platelets will start attaching to this collagen fiber. As platelets attach to this collagen fiber, eventually, theoretically, this collagen fiber is going to become completely saturated with platelets. The only other way to activate platelets is to have another collagen fiber. But what about these platelets that are floating by way up here? They're not going to attach to any collagen fiber. So how do you activate these guys up here? The way you activate those is through chemical mediators like thromboxane 2 and ADP. These platelets down here release these chemicals, and as they float by the bloodstream, in the bloodstream, they will activate this platelet and it will also attach. It will activate this platelet and it will attach. So that's the importance of having these chemicals released to activate these platelets. Not all of them are going to attach to the collagen fiber to be activated, so you need to have a chemical that activates them. That process that was just occurring right there is the beginning of the clotting process. Now that the ADP and the thromboxane are in the bloodstream, what happens is all of the platelets in the area start to get sticky, as it were, and they begin to adhere to the original platelets that are now covering all of the collagen fibers down here. So you have to get more platelets down here to do this. Eventually, the number of platelets will increase to form a massive platelet plug. Now, this is just a plug. This is a temporary plug. This is the finger in the dike, as it were. This is a temporary plug to keep the blood from continually flowing out. Unfortunately, it's not flowing out. It's all occurring inside the bloodstream. Now that we have the platelet plug, we have to develop the clot. The plug, like I said, is a temporary measure, not a permanent fixture. So we need something that's still temporary, but not quite so permanent that it will never disappear. So now that we have a platelet plug, we need to develop a clot. How we develop a clot, and this is where I'm going to skip a whole bunch of stuff. All of this stuff right here, this is, if you ever take an anatomy and physiology class, a true anatomy A&P class through a university or a college, you're going to have to learn all of these processes in painstaking detail, but I'm going to skip over a whole bunch of them. I'm going to bring you the important stuff here. Through a complex mechanism of clotting factors, enzymes, activated platelets, phospholipids, and calcium, a specific substance called prothrombinase is formed. This whole process here, prothrombinase, is formed. Now, as a side note, anything with ASE at the end is considered an enzyme. An enzyme converts one substance to another substance with very little heat and very little energy. So prothrombinase is actually formed. Everything on this side of the line is already free-floating in your body, which is prothrombin and fibrinogen. Once prothrombinase is formed, the prothrombinase, with calcium and some other stuff, changes free-floating prothrombin Prothrombin is created in the liver. It creates prothrombin into thrombin. Now that we have thrombin, thrombin now acts as another enzyme or a catalyst. Remember, everything on this side of this line is already free-floating in the body. So thrombin will then convert the soluble fibrinogen which is a free-floating protein in the body or in the bloodstream. It converts soluble or free-floating fibrinogen into insoluble, or it makes these little fibrin threads. It makes insoluble fibrin. It is no longer dissolved, it is now solidifying inside the bloodstream. Fibrin then becomes the thread-like substance that makes the clot more sturdy. So basically what can happen is you can have all of these little, we'll say these are little fibrinogens down here that are just free-floating in the bloodstream. As they come in contact with thrombin, right here, as this free-floating fibrinogen becomes in contact with thrombin, what will happen is the thrombin will cause a fibrinogen to start bonding basically together. It's not truly bonding, but that's what it does. They get put together like this to create fibrin. This right here is your fibrin thread. Now this fibrin thread right here is basically going to be the scaffolding for this clot, to keep this clot together so that the body can continue to repair that area. Once again, this is fantastic if it's occurring because you cut yourself shaving. Not a good thing if it's on the inside of a coronary artery. Feel free to play any of this stuff back on the video, of course, to try to help understand it as well. What prevents clot formation? There's advantages and disadvantages to the clot formation process. One of the advantages to the clot formation process is that it is a very fast process that prevents you from bleeding. One of the factors of the clot process is that it is basically a step A through B through C through D all the way through the end. The problem that occurs with that is that if you interrupt that process anywhere, you stop or slow down the clotting process. There is no secondary route. There is no collateral process to try to prevent or to try to build a clot. So if you take a medication or you have a disease process that prevents you from clotting, you're in trouble, or it's a good thing, one of the two. So what does aspirin do, actually? When we talk about aspirin, what does aspirin do to prevent clot formation? Well, basically, aspirin keeps the thromboxane A2 from attracting other platelets and causing vasoconstriction. So basically, aspirin is a platelet aggregate inhibitor. So it prevents the aggregation or the platelets from collecting to try to build a platelet plug. It prevents them from coming together. Coumadin, on the other hand, is another medication also called warfarin. Coumadin slows the production of prothrombin in the liver. So if you have less prothrombin available to you, it doesn't matter how much thrombin you have. You could have tons and tons and tons of this thrombin right here, but if there's not a lot of prothrombin available to convert, then you're going to have a very slow building of a clot. Heparin, on the other hand, it will actually inactivate thrombin. So when heparin inactivates thrombin, your free-floating fibrinogen cannot convert into the fibrin threads. So if you inactivate the thrombin, fibrinogen, a free-floating protein, is just going to continue to be a free-floating protein. It's going to continue to stay dissolved in the plasma. It's not going to convert into these fibrin threads right here to try to build a clot. It's not going to happen. Of the Coumadin, aspirin, and heparin, which one of these are most commonly administered in an emergency situation, for example, as pre-hospital paramedic medicine or in an emergency room? Heparin and aspirin. Those are kind of short-acting. They can be administered. They don't have to wait for very long for them to start causing their effect. On the other hand, Coumadin is usually given out of the hospital. Why? Because it has to actually slow the production of something in the liver. So you can't really give Coumadin in an emergency situation if somebody's having a heart attack right now. Sure, you can give it later, but initially you're going to be giving the person aspirin, possibly heparin, possibly even something called a fibrinolytic, which breaks apart the fibrin threads, which we will discuss later. Acute coronary syndromes. I'm going to run through this pretty quickly here, and then we're going to be done with this particular presentation. But the first thing I want to talk about is an acute coronary syndrome is basically a condition caused by a transient or permanent obstruction of a coronary artery resulting in an interruption of sufficient blood flow to the myocardium. There are 3 types of problems that will cause an acute coronary syndrome. The first one is called angina, or angina, depending on how you learned how to pronounce it. The second one is called ischemia, which is an ST segment elevation myocardial infarction. And the other one is called a non-STEMI, or non-ST segment elevation MI. Angina is something we're going to cover pretty quickly here. STEMIs and NSTEMIs, we're going to talk about those later on in the presentation. Angina or angina pectoris is basically a discomfort in the chest that is caused by myocardial ischemia. Angina is only considered the signs and symptoms. They're having anginal type pains, basically. Just because you have angina does not mean the person is going to have changes on the EKG. A lot of people say, well, the person is complaining of chest pain and shortness of breath, but the EKG is normal. EKG changes are not always seen in anginal pains. What happens is the discomfort comes from stimulation of nerves that are due to carbon dioxide and lactic acid buildup. What happens is when you have this process occur right here, the immediate area that is being affected becomes acidic, or the pH drops. When this pH drops, nerve endings are stimulated that send messages to the brain. Basically, they're pain nerves, and they're sent to the brain, and the brain goes, oh my God, we're having some pain. But we don't always feel it as a pain. It could also come across as a discomfort or a weird feeling of some kind. These lactic acids, carbon dioxides, all of these little things that are building up due to ischemic tissue come from the blockage of that coronary artery. A lot of times they're described as the chest itself is sometimes described as a pressure or a squeezing or a strangling, a constriction, a heaviness. It is not really considered pain anymore because a lot of times people will say, how bad is your pain? I don't have pain. I have pressure. To some people that's actually different. They can usually be located on the sternum, the neck, the jaw, epigastric, which is the upper abdominal area, arms or arm, one or both of the arms. It's not always specific to one arm or the other. It used to be if it's radiating down the left arm, then it's a heart attack. Well, it could also radiate down the right arm and still be a heart attack, including the scapular region, which is on the back. Some cautions about anginal pains. If they are sharp pains that are increased by cough or movement, this one is still questionable. It is possible that somebody who is having anginal type chest pain could have a heart attack. If nerves are being stimulated, if pain nerves are being stimulated due to lactic acid, carbon dioxides that are causing a dropping of the pH, which are causing a stimulation of those nerves, if you go palpate the chest, it is possible that you could increase their pain by palpation. So do not use chest pain increases with palpation as a rule out diagnostic tool. You cannot do that. If you palpate the chest and the pain increases, it could still be a heart attack. Now, these other ones are pretty straightforward. Brief pains that only last a few seconds. If you have a sharp twinge of pain in your chest and it goes away after a couple seconds, probably not, more than likely not a heart attack. Pain that starts in the chest and radiates to the lower extremities. More than likely, that's a pretty good chance it's not a heart attack. Maybe an aneurysm, but not a heart attack. Pain in the middle to lower abdomen. Any pains that occur above the umbilicus or the belly button are considered cardiac until proven otherwise. Any pains that occur below the umbilicus or the belly button, probably you can bet that they're not going to be a cardiac type pain. There are three major types of anginal type pains. There's something called stable angina, unstable angina, and there's another one here that I'm not going to discuss today, but it's called Prince-Metal. Prince-Metal pains. I'm not going to discuss that today, but I'm going to talk a little bit about stable versus unstable. The easiest way to remember stable versus unstable, stable anginal pains are considered predictable. If they're predictable and the person has a history of these type of pains. So they're predictable when it comes to the frequency, the severity, the duration. Usually if they last less than 2 to 5 minutes, we're good. But if it starts exceeding 20 minutes, even though it's predictable, and even though it's stable, it's considered unstable. You know the precipitating factors. For example, you know that if you overexert yourself while you're carrying in the groceries and it's extremely hot outside and you cause a lot of stress on the body, or you climb a bunch of stairs, that you're going to start having these anginal type symptoms. But you sit down, you relax, you drink some water, you maybe take some nitro, then the pain goes away. The pressure, the symptoms, whatever, they all go away. So they're predictable at onset. They're predictable on how to alleviate everything. Stable angina and a history of is considered stable. All of that is considered stable. Transient episodes of any of these symptoms: chest discomfort, shortness of breath, palpitation, sweating, nausea, vomiting. Hopefully transient vomiting. Unstable is when there is a change in the predictability or it is a new onset. These are the two keys that make it unstable. Symptoms that occur at rest or minimal exertion. Okay, symptoms that last more than 20 minutes, that's automatically considered unstable. Symptoms that are new or more severe, that would be a change in the predictability if they're more severe. Symptoms that are prolonged, for example, longer than 20 minutes. Symptoms that are more frequent with pre-existing stable angina, that would be a change in the predictability. So if there's a change in the predictability, or it's brand new. Now, one thing to remember about the anginal type pains is a lot of people get frustrated because they say stuff like, well, the person is having unstable angina. And we have to remember that it's the angina that is unstable, not the patient. I don't know how many times I would receive patients that they would say the person is unstable angina, and I would be expecting this, oh my God, this critical patient that was hypertensive or hypotensive, tachycardic or bradycardic, pale, cool, sweaty, and I see the patient and they're pink, warm, and dry, sitting there playing a Game Boy or playing Angry Birds. And I would say, they're not unstable. They're perfectly fine. What I was mistakenly assuming was the patient was unstable, when in reality, unstable angina just means that the symptoms are unstable, not the patient. The patient could be perfectly stable. Ischemia. Now, ischemic tissue can cause stable or unstable angina. When we talk about ischemia in the tissue, what we're saying is that the muscles need more oxygen, more nutrients, but it's not receiving it. The metabolic needs exceed the supply of the nutrients. If the metabolic needs at the cell exceed the nutrient supply, technically the muscle goes into ischemia. Now, ischemia can be identified as one of two causes. There's supply ischemia and demand ischemia. A demand ischemia, all that is an increase in the metabolic needs, but you can't get the supply to the tissue. This is not caused by a clot. This is not caused by an occlusion. This just means that the metabolic demands are so high that the body itself cannot keep up with the need. An example of that is my favorite one here, which is tachycardia. Now, there is something called a rate-related tachycardia, where the heart can actually be beating so fast that the metabolic demands exceed the coronary circulation's ability to supply those nutrients. Not because there's a clot, just because it can't get the blood there fast enough. A supply ischemia, on the other hand, means that you are not increasing the metabolic demands. A demand ischemia, you increase the metabolic demands. A supply ischemia, you don't increase the metabolic demands, you just cut off the supply. So you're going to be perfectly at rest, and all of a sudden you start having coronary vasospasms, or the coronary artery is narrowing or blocked. This is a supply ischemia. It is blocking the supply, no change in the metabolic demands. But what would happen is, if you have a supply ischemia, the natural result is a sympathetic response due to a clot in the coronary artery. What this is going to do is it's going to cause a supply ischemia resulting in a demand ischemia. So you're going to end up with both. But the initial onset, what is it? Is it a supply ischemia or is it a demand ischemia? Tissue injury comes from if the ischemia does not get the blood flow, eventually myocardial cells will have difficulty repolarizing. What this means is in the cardiac cycle, in the phases of the cardiac cycle, if you remember this little thing right here, there's phase 4, that's 0, that's 1, that's 2, that's 3, and that's 4 again. This is the 5 phases of the cardiac cycle of muscle depolarization and repolarization. Phase 2 is where you stay in phase 2 a little bit longer, and what that does is, through a complicated system, is it causes ST segment elevation on the monitor. This is tissue injury, but the tissue can still be salvaged. Tissue infarction, on the other hand, if blood flow is not restored, the injury will infarct. In other words, the cells will die. Once the cells die, they are gone forever. You can't go in there and re-stimulate them or reperfuse them to start building up again. Once the cell is dead, it cannot be reanimated. So what happens is you lose the ability to conduct electricity and you lose the ability to provide mechanical contraction. And that opens, especially that second one there, that opens a door into so many different problems. It is better to prevent somebody from having a heart attack than to try to treat them afterwards, because if they have true infarction and tissue dies, it causes major, major problems from there. The next presentation that I would like to go into is the changes on the monitor, and these are the EKG changes on the monitor. Or the electrical, this is supposed to be an AL, or the electrical changes on the monitor that you're actually going to see.